Rosenthal, I think we can start, and I'm going to follow your presentation so I can call the panelists while you're presenting.
Sounds good. All righty. So my name is Dr Rosenthal. I'm one of the trauma surgeons up at University of Florida in Gainesville, and I was asked by Steve Smith and Jason Croft, who are two of my partners, to be a part of this. And so thank you for allowing us to share. And without further ado, I have no relevant disclosures.
Dr.
Here,
Martin,
yeah.
I'm sorry to interrupt you. Can you put your slides in full screen?
Let's see if I can go for that. Is that cool?
Yeah, it's perfect.
Is that better?
Yeah.
All right.
That's perfect. It's working.
All right. And so we have a 27-year-old male who came in to our outlying hospital. So we have a few hospitals, and one of our hospitals is in Jacksonville. This guy was actually admitted to Shands, Jacksonville with a gunshot wound to the right chest. He was stable. He was treated with chest tubes for a hemopneumothorax. Unknown volume return, so there was a conservative decision to not proceed to the operating room, but ultimately he had a persistent 2-3 chamber air leak on our normal Pleurovax, and this had been going on for a substantial period of time. Despite multiple chest tubes, even a video-assisted thoracoscopy with a mechanical pleurodesis, as we found in one of the op notes, and they even tried putting in doxycycline in through their surgically placed chest tubes to try and provide a chemical pleurodesis. So he had this ongoing issue. They could not get the chest tubes out. And ultimately, the surgeons there decided to send the patient to our hospital because we have interventional pulmonologists that have bronchial valve capabilities. And so they inserted these valves. They did 2 attempts over about 16 days. 4 valves were replaced. Still had, an ongoing persistent air leak. This is now pushing into, 8 weeks of this kid having this issue. And then repeat imaging was certainly concerning for this intraparenchymal chest tube that had been placed. Unclear when it was placed. But there was definitely some imaging that showed us that one of the chest tubes, likely the most superior one going into the apex, basically had speared the lung. And then he also had this tangential parenchymal injury consistent with penetrating trauma. Carlos, at this point, you want me to stop? Should we ask questions or just keep going and see what spurs of a discussion?
I think we can move on to the next phases. I just wanted to ask you about the chest tube. So it seems that they used pigtails or tubular drains.
Yeah, so they did 40 French chest tube. They also had IR placed some pigtails, none of which ended up resolving any of the pneumothorax.
So
And he,
the one that pierced the lung was the tubular.
oh no, that was a surgical chest tube. That was one of the big 40 French ones.
Wow, really? Okay.
Yeah. All right, so being a glutton for punishment, I made the decision in taking this young kid to the operating room only because all the imaging that we ever had showed this pneumothorax. Clinically, it was a persistent air leak. Clinically, removing the chest tube that had speared the lung wasn't going to fix the other parenchymal injuries, and ultimately, his wishes were to just get out of the hospital at this point. Um, Going back on a reoperated VATS who had a chemical and mechanical pleurodesis was not going to be fun. We already knew that was going to happen, but we were actually able to get into his chest with relative, I say relatively no issues. only to say that he was a really, really skinny male, and the finichetto actually would not fit through his rib spaces. So I ended up having to resect one of his ribs in order to create enough space to have a retractor placed in there. So obviously, this decision wasn't made lightly. I spoke with Steve Smith, who's got a world of chest trauma experience, and we went in and we found that the 40 French chest tube was certainly through the lateral superior middle lobe and superior lobe to the apex, and then we saw the tangential injury. It's kind of a poor photo, but here you can see that the burlisher is actually going through the parenchyma and is pointing at it. We did our rib resection. We did 2 tractotomies, one for the chest tube and one for the ballistic injury, and we oversewed the air leaks, sprayed a bunch of fibrin glue on the raw surface areas that were denuded when we were doing our kind of lysis of adhesions. I ended up doing cryoablation. I think it helps with pain control post-op. And I even had enough time to have our pharmacy prepare a paravertebral catheter. We usually put in a grenade of basically local anesthetic as a paravertebral. And when you know it, after the operation, everything worked. There was no air leak, but not because everything went great for the first day or two. He ended up developing post-operative bleed, likely from the intercostal artery that I had resected the rib from. Um, the decision, because he was stable, was to essentially embolize that vessel, and then we were able to hook up our CLR, or the clear irrigation vac, and was able to suck out the remaining hematoma without having to reoperate on this 27-year-old male. But then after about a day or two of doing the CLR, we noticed that the air leak came back. And I wanted to kick myself for not having gone back in and evacuated the clot. For points of discussion for the folks attending our Zoom, could it have been that the irrigant that we used washed away the fibrin glue? Does it, did the etiology of having a bleed and having to put the chest tubes back to suction, did that potentially erode into a small airway? But ultimately, we sat on him for a while. He ended up getting one more of those endobronchial valves placed, and it worked. And now he's discharged home with radiographic evidence of no pneumothorax, and he's coming back for follow-up in about 2 to 3 weeks, actually, to get his endobronchial valves removed.
So, can I ask you some questions?
Yes, sir.
2 questions before I open for the panelists as well. Maybe I'm going to see who's up to make some comments as well. But the first thing that I wanted to ask you is about the thoracotomy while in a patient who had the pleurodesis. So did you have? I mean, could you walk us through your procedure? Because I'm thinking with myself here. How difficult that would be to get into the chest cavity after the pleurodesis, and I have never had the experience to perform a thoracotomy in a patient who had a pleurodesis. So I wanted to ask you about some tips or some of the walkthrough about the procedure for us.
Sure. So we did a standard positioning. We went lateral beanbag, and then made a kind of a lateral, anterior lateral thoracotomy, more lateral than anything. Ultimately, I have no tips because he had very minimal adhesions. Once I made the thoracotomy, the hardest part was carefully getting into it. But once I was able to get into the chest, I bluntly dissected with my finger and was able to remove a portion of the adhesions without damaging or injuring the lung further. And that was a huge surprise to me. It was actually wonderful because It allowed us to actually get access to the remaining chest, and then some of the other posterior adhesions and some of the adhesions to the apex of the lung were a little bit more challenging to get. And I think that was because that's where the chest tube had basically gone through the parenchyma of that lung. And it looked like he was starting the early onset of maybe an empyema. And so some of those adhesions were a little bit more tenacious than the ones that were around the seventh rib where we had entered. So, I mean, again, I'm not saying or advocating to do thoracic surgery on somebody who's had both a mechanical and chemical pleurodesis, but he did not respond the way that you or I would probably think he should have responded to the pleurodesis, if that makes sense.
Oh, it makes perfect sense. So let me see if there's someone to comment as well. I see Dr. Frisby in our meeting. Dr. Frisby, do you want to make some comments or ask any questions to Dr. Martin? So Dr. Frisby, Dr. Kassim, I don't know if you are available as well for comments, because I have a bunch of questions, Dr. Martin. So if no one's going to ask
No,
you,
you go ahead. You go
oh,
ahead.
Dr. Frisby.
No,
No,
you
but
go
please.
ahead. Believe me, it's been a long time since I did a chest case. Go ahead.
No, no worries. Thank you very much. So I see Dr. Kassim as well. Dr. Kassim, if you want to make any comments, feel free to open your mic and speak up. I also see. Oh yeah.
This case brings back a lot of memories. About almost 40 years ago, I did my thoracic training in England, and we used to see a lot of these, pneumothoraces from failed um, chest tube treatment at that time. And my boss used to tell me, don't beat a dead horse. He had certain amount of time he would devote to conservative treatment to correct the pneumothorax. And if it doesn't resolve, and there must be a reason for that, and he would get very aggressive. And one of the things that we do is that when something like that fails, then we have a junior resident to put in the chest tube. And there lies the problem. And the chest tube goes through the parenchyma, and now you have an iatrogenic injury. So you have double whammy. Be as it may, like Dr. Martin says, it is quite treacherous to go back into the chest that when you have done chemical pleurodesis. In England, we used to use talcum powder. And of course, if you do that, you are now facing lawsuit from the lawyers if the patient should develop some type of a malignancy later on. So they don't do that. And we also used to use tetracycline in those days. And since I've been in practice, I haven't had a lot of failed treatment for pneumothorax, but I have seen a bronchopleural fistula due to trauma and manifest itself with a persistent pneumothorax and requiring treatment. I think my advice to young surgeons who are coming up in this field of surgery, have a very clear view of what you're going to do, and you pick one or two conservative measures. And if that doesn't work out, you have to take the bull by the horn and fix it once and for all. Tracheotomy, in my hand, doesn't work as well as doing a resectional surgery. You identify this, and how do you identify this? You have to do a bronchogram. You need to identify exactly where the hole is and where it's coming from, so that when you take the patient to the operating room, then you know what type of resectional surgery that you're going to perform. And be aware, post-operatively, you're a sitting duck for some type of empyema, because this has been allowed to fester. You don't know, how well the tubes were placed, or they were placed aseptically, religiously aseptic, and all those factors come into play. And the pleural cavity may be contaminated, and you have gone in there and allowed blood and all the other stuff to accumulate a little bit. And I'm glad Dr. Martin didn't encounter empyema. I was looking for him to tell me, well, we had a small empyema, we had to treat that too. Um, these are very complicated problem. I think you need um, you need caution. You need to get a plan what exactly you're going to do and avoid iatrogenic problem. And I would like to hear more other people chime in too. Thank you.
Great, thank you, Dr. Kassim. Dr. Martin, a quick question: did you perform a bronchoscopy before getting this patient to the OR? I don't know if I missed this part of the presentation.
Yeah, he had a bronchoscopy actually in the OR with me, but he had previous bronchoscopies. He had at least 2, maybe 3 rounds with our pulmonary interventionalist putting the bronchial valves in. So I don't know. One of the reasons I wanted to present this is like I don't know what everybody's experience is with these valves, but they didn't work the first 3 times, and then miraculously the last time he had it after he redeveloped an air leak, it worked. And so my understanding was that you can put and place these valves in tandem. So if one valve doesn't stop the air leak, you put a second one in front of it and you keep just stacking it up in the airway until the air leak essentially goes away. Even when we were doing our tracheotomy, I was very concerned that I was going to fire a stapler load across one of these valves. And it would make the stapler malfunction. When it came to the decision of taking this guy, we had tried every conservative measure you could possibly do. We even thought, well, shoot, maybe we shouldn't operate and just give this guy the old school Heimlich valve and pray to God that he gets better over time. But at this point, it had been almost approaching 8. He'd almost been in the hospital for 2 months as a 27-year-old. Like his girlfriend was sleeping with him in his hospital bed because she'd basically moved in at that point. And so, I wanted to help him, and I knew it was going to actually be one of the worst decisions of my life, but it ended up being okay, which is not a good way to practice medicine, but at least he did fine. I thought it was going to be terrible to go in with all those adhesions and the pleurodesis and stuff, but it ended up being okay. But we also had a very upfront and frank conversation with him saying, listen, if I can't get in, I'm going to abort. Like, this is not something that we're going to mess around with and potentially destroy this kid's lung. The decision to do the tracheotomy as opposed to the lobectomy was because 2 of the lobes were injured on the same side, and I didn't want to go taking out the upper and middle lobe on him. Especially, the reality was I felt comfortable with doing the tracheotomy, and I did not do upfront PFTs on him to get him better and to potentially result in a bilobar lobectomy. And so I probably, in hindsight, should not have admitted that to this group, but the reality is you should always be prepared to have to do a bigger operation on something like this. And we probably should have had the PFTs before we went charging into his chest.
Interesting. So I'm going to call Dr. Veron for a question as well. Dr. Veron is a very experienced anesthesiologist, and we are so fortunate to have him here in this meeting, and he's been participating in previous meetings as well. And this is one of the great things about this meeting. We can have a lot of opinions and expertise from various professionals. So it's very fortunate to have him here. So Dr. Varro, I wanted to ask you about the management of these cases, especially when considering maybe not in this time, like 8 weeks before, 8 weeks after the trauma, but is there any particular thing that we need to be?
I think that the most important thing is good communication with your anesthesiologist, because right now you are, the patient is breathing spontaneously. There's no positive pressure. Once you anesthetize the patient and use positive pressure, you're going to make things much worse. You can have a tension pneumothorax. You can have all sorts of problems. So there has to be a discussion, where you're going to be operated. Do you need one lung ventilation? And if we use one lung, how are we going to do that? Bronchial intubation, not everybody tolerates that. A bronchial blocker, which is probably better for patients that are intubated, or a double lumen tube, which would be better for patients who are not intubated and who may have a possibility of empyema. That's a big deal. We need to know there's an empyema, because the only way to isolate the other lung and make sure that that pus doesn't go to the other side is by putting a double lumen tube. And in this case, if you're working on the right, then a left double lumen tube would be ideal in that circumstance. Also, we rarely do this, but it is really a big fistula and you want that to heal. And let's say the patient has, not this case, but the patient has severe respiratory failure. Applying PEEP to both lungs may disrupt your, whatever you fix. So you may want to consider occasionally to leave the double lumen tube to apply differential PEEP, and PEEP only the good lung and not the one that has the fistula. So again, I think good communication in determining what you're going to do, the size of the injury, if the patient is going to be intubated, if the patient is doing pre-op and or post-op, all those things need to be discussed to avoid any catastrophes in the OR.
Oh, that's great. Great insight about the empyema as well. Dr. Croft, you get your hand raised. Do you want to make some comments or ask any questions?
Yeah, I just wanted to make some comments. First of all, I'm Martin Rosenthal's partner, so I want to thank him for presenting this case. This was obviously a very challenging case, but I want to go back to one of your initial questions about how do you manage getting into the chest in somebody who's already had pleurodesis or previous thoracic surgery. And the only tip that I would suggest is you've got to take your time. This is no different than going into an abdomen that's been operated on a million times and there's a bunch of adhesions. And if you don't take your time and carefully take down the lung, you're perhaps going to make the problem worse. Because, as I'm sure everybody on here has experienced before, the lung is very, very delicate. And if you try to just rip that parenchyma down off the chest wall, you're just going to tear the capsule and cause further air leaks. So I think Dr. Rosenthal did a great job of getting in the chest. The other key is taking your time when you're putting in your retractors, because it's also very easy to inadvertently tear the lung with just putting in your retractors. I also want to go back to Dr. Kasim's comment, which I want to thank him for this comment about the bronchograms, because that's not something that we do very frequently anymore. But it should still be something that's in our toolbox. And don't forget that is very helpful in identifying exactly which bronchus is leaking so that it can guide your treatment. And then finally, the other thing that I'll bring up, for patients who have really significant air leaks that you can't control, say you've already operated on the patient, they've got a bad bronchopleural fistula, another option, sort of a last ditch thing, would be to consider doing single lung ventilation and just isolating the other lung, allowing the bad lung a chance to heal before going back and re-expanding the lung and see if you can get the hole to heal. So just another thing to consider. But thank you for presenting this as a great discussion.
Thank you for your comments, Dr. Croft. So I see Dr. Valenzuela as well. Do you want to make any comments, Dr. Valenzuela, or any questions to Dr. Martin? Feel free if you like, just raise your hand as well, and we can call you. So I just wanted to ask another question about the actually about the rib resection. So could you also tell us how did you perform this? Are there any tips for us that don't do this often? Or I mean, I personally have never seen this for trauma patients. So do you have any comments on that?
Yeah. So when we were trying to get our exposure, when I say his intercostal space was so narrow, it literally would not fit the closed finichetto to get in there. And so ultimately it was going to be either break the rib or resect the rib. And we started out with breaking it, but it was more amenable to resecting it. There's two things that I found were probably what led to the post-operative bleed. One was either at the moment where I oversewed the neurovascular bundle, maybe that stitch became dislodged, or when I actually went to close down the intercostal space, I used big, like number 1, number 2 vicryls, and I don't know if I snagged the intercostal bundle with the stitch. So, but when I resected that, we try and go as posterior as possible. Got the rib cutter, cut the rib out, and then used a little rasp to dull the edge of that rib down. It was actually pretty straightforward, and it's I come to find out that it's billable, so resecting a rib. You know, that's how they used to treat empyemas back in the good old days. They would resect a rib, marsupialize the tissue out, and let everything drain out from tuberculosis and stuff.
Right.
Yes, Dr. Kassim.
It was called butcherous thoracoplasty. Horrible operation. And I was a resident at that time, and I used to cringe every time I was asked to call in to assist with my chief surgeon there in England. That's a horrible operation, and you don't want to be involved in any of those, and you should. Hopefully, you never come to do one of those. That's a terrible operation.
Yes, I remember seeing that on my thoracic surgery classes here in my country, because we have some cases of tuberculosis, and then they would tell me about this type of situation, but I've never seen for trauma cases. That's why I'm so curious about that. Very interesting. And I have another question before I move to the other panelists as well, to make sure that they don't have additional comments. I would like to ask you about the irrigation of the thorax. So we are seeing more and more papers being published about treating hemothorax with irrigation in the index drainage. But how do you feel about using the irrigation for cases that are a little bit late in their presentation, just as this one? So do you have any experience with that? How are the results that you've seen? Any comments on that?
Yeah, you know, Dr. Croft actually might be able to answer that a little bit better. So Dr. Croft was the one who brought the CLR to our institution. You know, I feel like we're not doing nearly as many VATs as we used to for retained hemothoraces. So I think from that standpoint, it's working. And when it works pretty quickly. You know, with this acute bleed, I was hoping that the clot wouldn't be as gelatinous and would easily just irrigate out, which in fact it did. But then I think just the sheer volume of the post-op bleed, he still had a little bit left in there. As far as using it for other indications other than hemothorax, I have not had that experience. I don't know, Dr. Croft, have you used it on like an empyema or anything like that yet?
Yes, we have, and it actually works great. We're in the process of actually doing a DoD study, not looking at necessarily late irrigation, but we're looking at using irrigation on all hemothoraces. So as soon as somebody comes in, gets a chest tube, we irrigate the chest, and we do that for 3 consecutive days if there's evidence of retained products. And we're looking at our rates of retained hemothoraces, need for secondary procedures, and need for VATs. And so far, I can tell you that of all the patients that we've irrigated, no patients have had to go to the operating room or get a second procedure done for empyema. And I hope to present that data hopefully in the next 6 months once our study completes. As far as patients who already have empyemas, it does work. I've used it a handful of times. I've had 2 patients that were shot thoracoabdominal gunshot wounds with intra-abdominal contamination in the chest, and we were able to successfully get both of those patients through without needing chest exploration. So I'm a big proponent of it. I think most of us have done chest irrigation for a long time, and we've used sort of the old methods and stuck things through the chest tube and put endotracheal suction catheters through the chest tubes to try to aspirate the chest, and it never really works very well. And now with this new product, I think it works great. So I'm a big proponent.
And not to say for not, but you can irrigate with different solutions. And so some of these antibiotic solutions that we have out there, like Irricept, which is dilute chlorhexidine, I think would actually further decrease, potential for empyema and whatnot. But our protocol here, I believe we just do saline irrigations.
Yeah, and the other thing, you can also use lytics, so you can administer TPA or Dornase through the chest tube. The other advantage is it's a closed system. So if you want to do multiple irrigations, it's all a closed system, so you don't have to keep disconnecting the chest tube in order to irrigate. You just plug right into the system and irrigate, and then disconnect, and it's got a sterile cap that you can put on it.
Nice. Yeah, I saw some presentations of the Clear device in the last AAST meeting in Las Vegas. It was really interesting to see the experience of everyone using it. Very interesting. Okay, so I'm going to go to the panelists again to make sure anyone has any other additional comments. Dr. Veron, I don't know if you have any comments. If you do, just please open your mic and feel free to speak up as well.
No, I don't have any additional comments. Thanks for this great presentation.
Thank you, Dr. Veron. Dr. Kassim, do you have any additional comments?
One other trick that we used to use initially, if your chest tube is not doing the trick, we used to do a pneumoperitoneum and allow the diaphragm to go forward, move upward, and see if it could reduce the space in the apical area. Probably that wouldn't have helped in this particular case. It's something that you want to keep in mind. It's again a minimally invasive procedure. Thank you.
This is Julie Valenzuela. Sorry, what a great case, and I don't know that enough of us have experience going back into a redo chest, so all my accolades to you. But so is the feeling that the 40 French chest tube was ultimately the issue?
Yeah, I think it certainly contributed. I can't tell you exactly what proponent, because we did not do a bronchogram, but I can tell you that when we did the tracheotomy, the area that bubbled the most when we submerged the lung and reinflated it was coming from that chest tube area. And so one of the concerns that we had was, do we pull the chest tube out and see if the lung will just heal itself?
Right, and that was my question, right? Like, any considerations? Number one, I'm surprised anyone's using 40 French chest tubes, to be quite frank. I have moved away from that a very long time ago, but I guess that was my main question, was there any consideration just to remove it and see what happens?
Yeah, we thought about that, and there was still the concern with the original injury. It wasn't 100% confirmed you know, when I was looking at the CT scan, it was like kind of like, you know, tilt your head and stare at this for a half a minute, and was it tracking with the fissure, or was it? And ultimately, I was pretty convinced that it was going through the lung, and you could still see the damage from the ballistic. So, you know, hindsight's 2020. Should I have just pulled it out and prayed? Probably. Could I have? Because I don't, you know, I don't think putting a Heimlich valve on that chest tube would have done anything for him other than left the
Right.
foreign object in the lobe. So I think pulling it out and then maybe getting, if you needed, you know, another tube to go back in, that might be where we ask our interventional colleagues, because, you know, finger dissecting into that area, that space was going to be problematic, let alone going back in there. So we could have certainly tried that for sure. I'm not going to disagree with that.
I'm just curious. I understand the complexity of the case of decision making, and I commend you for getting him great results. So just curious what other, for yourself and your colleagues and the other panelists, if they would have considered just taking the chest tube out. And I'm also curious about, I know irrigation, we're actively doing that. I was also previously a big proponent of the YATS, kind of as you're putting it in, yank hour, to take out any hemothoraces. Wondering if anyone else utilizes that practice.
I've done that, but I don't think I do that routinely. And I think with the CLR, it's a lot, like Dr. Croft was saying, it's you know, it's an isolated circuit. So I think it's easier and less of a chance to introduce bacteria into the system than the Yankauer method. Jason, do you have any comments on that one? I saw him take his mute button off. I don't know if
Yeah, not me as well. Okay. Okay, so let's see, Dr. Cassim, yeah, as already said. I don't know if Dr. Croft, do you want to make any additional comments as well before we close? I don't think so. Well, I think not. And Dr. Frisbee, I don't know if you're there, still there, but if you want to make any comments, just feel free to open your mic and speak up.
Very good case. Very good.
Thank you.
40 French is a little big. You know, it's kind of scary. But when you're in the heat of battle, you use what they hand you. And I don't know, the discussion about whether there was enough experience behind in the hand, but 40 is pretty big. I probably would have done a 36, but I think that's just personal preference. You did a good job. Real good job.
Yeah,
Nice
I usually shoot for 36, something a little smaller, 32, 36, something like that.
Yeah. Good case.
think,
Thank you so much.
my pleasure.
Yeah, that's great. So before we end the discussion, I just want to remind everyone that I'm gathering data from people who want to share want to present, or who want to be a panelist in these meetings. So if you are watching this and want to be part of presenting or debating the cases, please feel free to send me an email. I just put my email on the chat. You can just send me an email and we can arrange for your presentation and your participation as a panelist as well. And Dr. Martin, Dr. Croft, thank you very much for presenting the case. It was really, really interesting. I learned a lot in this meeting, as usual. So it's very interesting for me as well to be participating. And please feel free to join us in other sessions, other meetings. And if you want to present any more cases or be a panelist as well, just send me a message and we can get you hooked up in the group to participate more in this meeting as well.
Awesome. Thanks for having us.
Thank you, everyone.
Thank you very much. Bye-bye.
Thanks for coming.